Hello, everyone, and welcome to today's program, Managing Population Risk, Industry Insights Reveal Key Strategies, presented by SCIO Health Analytics and hosted by HealthLeaders Media. My name is Erica Randall, and I'm Senior Managing Editor for HealthLeaders Media. I'll be your host for today's webinar. Our program is 60 minutes in length. The format of our webinar today will begin with a brief review of the survey methodology and survey results from healthcare leaders and what they think about managing population risk, followed by a question and answer discussion with our panelists. We will then close the program by taking questions from our audience. Today's program is being recorded. Before we get started, I'd like to take a moment to just review the web conference platform that you'll be using. First, just to ensure that you can see all of the content for the event, please maximize your event window. Second, please be sure to adjust your computer volume settings or your PC speakers so that you can hear optimally. Third, at the bottom of your console are multiple widgets that you can use. So to submit a question, click on the Q&A widget. Now, it may already be open and appear on the left side of your screen, but you may submit questions at any time during the presentation. Just however, please note that it is likely that your questions will not be answered until the Q&A portion of the program for the audience. Should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. We're very pleased to offer you this free educational opportunity by SCIO Health Analytics. Now, I'd like to introduce today's speakers. Our first speaker is Donna DuLong, MSRN FHIMSS credentials, Senior Consultant for SCIO Healthcare Analytics. Ms. DuLong is a Senior Healthcare Executive with the SCIO Health Analytics company and has more than 25 years of clinical operations and informatics expertise in a variety of settings, including provider, academic, and healthcare technology companies. Donna is focused on promoting patient-focused care and the effective use of data to advance health outcomes through technology-enabled transformation across the healthcare industry, with proven success in developing new markets and improving products and delivery models in both startup and growing organizations. Ms. DuLong has a master's in nursing leadership from the University of Colorado and a bachelor's in nursing science from Michigan State University. She is also an adjunct professor at the University of Denver in the Healthcare Leadership Program. Welcome, Donna. Our next speaker is Dr. William, but we're going to call him Bill, Aberizk. He is the provider of education administrator for Yale New Haven NEMG. And Bill is the clinical education administrator at Northeast Medical Group, Yale New Haven Health System. He graduated from Harvard College, went on to medical school at Columbia College of Physicians, and he completed his residency at Beth Israel Hospital in Boston and fellowship at Harvard Medical School's Radiation Oncology Department. He was an associate professor of medicine at Harvard Medical School. Prior to moving to Yale New Haven, he was a radiation oncologist at Hartford Hospital and University of Connecticut. Welcome, Bill. And finally, before we get started, please note that an on-demand version of this program will be available approximately 1 day after the completion of the event and can be accessed using the same login link that you used for the live program. Also, a copy of today's presentation is available in the resource list widget, which is located in the lower left area of your screen. Now with that, I will go ahead and do a brief review of the survey methodology and survey results that we asked HealthLeaders Media audience in February and March 2008. It's a 9-question survey in which a total of 101 completed surveys were included. The margin of error for this base of 101 is plus or minus 9.8% at the 95% confidence interval. And let me just go ahead and put up on the screen the slides that I'm going to be talking through so you can also see. So I'm going to push that to the audience right now. All right. Okay. Regarding our respondent profile, the distribution of title sets shows a pretty senior group. It's aggregated as 73% between the clinical and CEO leadership. Health systems and hospitals made up 75% or 3/4 of the types of organizations where respondents work. For the type of organization, it's mostly an even distribution between small, medium, and large organizations regarding the size of organizations who responded. Also, organizations who responded are generally large because if you look at the percentage of respondents who say they have 50 or more physicians, it's at 81%. For rural, this is fairly representative of, nonprofit or for-profit organizations. This is fairly representative of what we see regarding the types of respondents to our surveys. And lastly, nearly 1/4 of the respondent base are at least $1 billion or more entities who responded to the survey. Now let's go on to our survey results. So for this slide, most respondents say that they are prepared. That's good. 73%, if you look at the aggregated, are very prepared or somewhat prepared to manage additional risk. But if you look at slide 2, as we compare this slide with the results from slide 1 indicates that 73% are able to take on more risk, but here we see that 32% are actually planning to do so. So we have the prepared, but out of those are those who are actually planning to manage the risk. For this slide, we have a split in responses where half say that the EHR system for analytics gives them a very comprehensive or somewhat comprehensive view as those who use traditional analytics. By aggregating the columns of very comprehensive or somewhat comprehensive, you will see that EHR for analytics systems and traditional analytics roughly tie at 53% each. There are no big surprises here for these results. 63% of respondents cite lack of resources as their greatest obstacle to gain a more comprehensive view. Most organizations may not have the expertise or people with analytics skill sets or the financial resources to upgrade tech or hire staff. Also, another number that isn't really a surprise is that 46% cite fragmented data ownership and data silos as an obstacle. And this is a well-known issue in the healthcare industry. This slide basically is asking respondents what you're using analytics for. The most prominent number by far is that 62% say that they use these to identify opportunities to close open care and documentation gaps. So basically, analytics is doing a good job in this aspect. We have a mixed picture here. Aggregated, we see that 42% and 15% strong ability and somewhat strong ability to take action. If you compare that to the 57%, whereas that comes from the 32% and the 12% that indicate that they have a somewhat weak ability to be able to leverage their analytic insights. So there's room for improvement here. This would be your usual list of shared risk arrangements. Basically, there's a cluster here where you see the basically the 58%, the 40%, 37, 36, 28, and this is to be expected. distribution is skewed here to the first 30%. If you look at the brackets, you can see the aggregate that adds up to nearly half, or 49% of respondents, who say that their current patient population is at risk is less than 30%. And finally, it's interesting to see that there is also a split in these results also. 46% have been managing their at-risk populations for more than 3 years. But notice that 45% in aggregate have been managing theirs for less than 3 years. And this could be a sign of momentum building. So that is a brief review of the survey results that we conducted. And now what I'd like to do is move on to our panel Q&A discussion with our speakers. I'm very excited to speak with you, Donna and Bill, about the survey results. So, Bill, I'm going to start with you. Oh, great. Thanks for being here. Bill, I'm going to start with you. The respondents of the survey appear to be relatively mature with their value-based adoption. As we noted in slide 1, 73% felt prepared to take on additional risk. From your experience, do you feel this is in line with the broader market?
From my standpoint, this seems like a very high number. I think it's being overly optimistic. And part of the problem is you don't know what you don't know. I would have said a year ago that we were prepared to take on risk and I felt comfortable doing it until we found out all the data that we didn't really have available to us. So I do think it's a high percentage, and I think with more experience about what data can provide, people might have a different opinion of what they want to do as far as accepting additional risk.
Excellent. And Donna, would you like to comment on that as well?
Yeah, I completely agree with what Bill is saying in that a lot of times the market may have, or providers may have a little more confidence in what they have until they start to see the gaps. And so they don't know what they don't know. And how well, how taking on additional risk is really about, and being prepared for taking on additional risk is really about truly understanding the population that you're managing and knowing as much about that population as you can, the demographics, their conditions, where they seek care and with whom they seek care and what types of services that they seek. And it really takes a pretty comprehensive amount of data to give a provider audience or provider organization taking on risk a complete picture that makes them comfortable, going into a risk arrangement, especially where they might have some downside risk or additional risk.
I would second that opinion about the downside risk. It's sort of easy to accept risk when there's no downside. As there's a downside, which is something we're about to experience, the decision about whether to accept downside risk, the data is even more important than when there is just upside risk. I can't emphasize how much more data we have in the last 6 months than we had before SCIO came and helped us. It's mind-blowing how much data is out there that you don't have access to.
As a provider organization.
Right, as a provider organization, exactly.
That's a good point, Bill.
Excellent. Thank you so much. Donna, I think you've touched on this a little bit, but I just wanted to see, how do you see accurate coding documentation supporting providers as they look to future risk and their next move to assuming more or new risk? Can you delve into that a little bit more?
Sure. So in a lot of managed populations, again, the drivers for revenue, for how much provider organizations get paid, is driven entirely by the documentation that's called out of the chart, applied on claims, and submitted to CMS, especially for Medicare populations. And if there are any gaps in that, if the claims don't go through to CMS, if there's any information missing, if the provider documented why they were treating the patient but didn't give a comprehensive view of all of the conditions that patient has, then they're going to have an inaccurate description of the population. And especially as that drives revenue, it puts them at a significant disadvantage to deliver care without being appropriately compensated for the care that needs to be delivered. And it's not just the provider organization that suffers from that. Patients do too. Patients that are in a managed population also benefit from accurate documentation and diagnoses because they have access to maybe disease management programs or care management programs, care coordination programs. So, it really affects the entire system if there is any missing documentation on those patients in that population.
Right. I would just add that we are being pushed, basically, into accepting risk by more and more payers. We have 3 Medicare Advantage contracts, and the other Medicare payers want us to accept risk. Initially, no downside risk, but definitely heading towards that. And we're also part of an ACO where risk is very important. And the information that we've been able to receive from working with SCIO not only tells us how many HCC codes, for example, are missing from patients, we're also given the RS, the risk factor per provider, and for the population of NEMG versus national benchmarks. All those make you see either you're doing really well or doing really poorly, and I'll say we were doing really poorly. And so it's instituted a whole educational process, chart audit process, and working with SCIO, we're really excited to see the benefits of working with SCIO and the results of what we're doing.
Donna, what do you think is driving the industry to need better analytics or visibility to risk adjustment within the populations that they are managing?
That's a really good question, Erica, and I think that CMS has publicly stated as they shift towards more value-based payment structures that they're shifting from being a payer of claims to being a purchaser of services, and that is outcomes-based. And so because of that shift and because of the way they're changing payment, it's really critical that they know how, are they spending their money right? Are they getting the right outcomes from the money that they're spending? And this is critical for any provider organization taking on risk, that they understand more about the population as well. They understand the outcomes. They have to deliver the outcomes. They understand the payments that they're receiving. And again, if those payments are driven by the documentation accuracy, they need to see if there's any gaps, if the way that they've documented the conditions for the population are off at all, if there's any gaps that are giving them an incomplete picture. So provider organizations are really hungry to be able to understand the entire population, understand how providers also are documenting and which providers are documenting on which patients. They need to see, as Bill was just mentioning, what are the documentation practices of all the providers in that population as well, because it provides in aggregate the risk not only for those patients, but in aggregate for that population, the benchmark, especially if they're in an ACO or an MSSP, it sets the benchmark for what they need to perform against. So they want more visibility from every aspect that they can to be able to better manage the population and predict their revenue streams and be able to budget for services accordingly.
I'll just add that CMS is really pushing this onto the insurers pushing it onto the providers. Mm-hmm. Even though this has started with Medicare Advantage, it's also affecting the ACO, and we see more and more commercial payers using some form of HCC coding in ascribing how we're doing as far as assessing risk factors, and eventually it's going to affect income. So the insurers need the income based on HCC codes, and they're pushing providers such as NEMG to really improve how we're, first of all, quantifying HCC codes, and second of all, just as importantly, as Donna alluded to, documenting HCC codes. And if we do a good job, the insurer makes money, and then in risk contracts, which we're heading towards on almost all payers, we will benefit as an organization.
Excellent. Bill, I was curious, the survey results, they revealed a relatively high level of satisfaction of providers using their EHR systems for analytics. to understand their current risk profile. What would you say are some strengths with using an EHR, and what are some of those key areas where there are gaps?
Yeah, I'm surprised by how many people are satisfied with the EHR for analytics. I think EHRs are great. We have Epic, which is a very good program. And it's very good for looking at things like quality gaps. How many patients have had mammograms, colonoscopies, diabetic eye exams? But it is not good, first of all, making sure that we're documenting patients' problems well, especially HCC codes. And it was really not, from my standpoint, very effective in helping capture HCC codes. We have a problem list that just gives a list of diagnoses, and it usually will say that this is an HCC code. But those are for only codes that were documented in the past and not recaptured. It says nothing about what the patient may have as far as conditions clinically, or even things that they find on scans or lab work that may be additional HCC codes. So the EMR, to me, is not very effective at all in capturing new HCC codes. It's okay in capturing things that have been captured before, but based on our work with SCIO, we know we're grossly underestimating the number of HCC codes that are applicable to patients. And it really is across our provider, from providers that see a lot of patients to providers that don't see a lot of patients. These are all primary care providers, and they're missing HCC codes is pretty much across the board.
And I'd like to add something to that. I think Bill brought up a really good example. You know, the electronic health record was designed for a different purpose, order entry and billing, et cetera, and giving a comprehensive picture of what's going on with the patient. But you took an example, let's say a provider is treating a quadriplegic. Well, the provider knows that's a quadriplegic. It's probably on the problem list. It's documented all over the EHR. But if the provider doesn't document that in a specific way every year to indicate that that is a paraplegic and that they're evaluating any issues that the patient may have and treating it accordingly, then that organization will not get credit for that particular condition from an HCC code perspective. That information will not go to CMS. The risk will not be adjusted accordingly. And it's, you know, it's something that is in the EHR and very evident, but it's a little bit misleading in that the provider doesn't know they have to document it in that specific way, and so they're missing out on that. And again, the EHR has a very comprehensive view of the patient and historically on the patient, but it isn't always ideally suited to the documentation required for risk adjustment purposes.
And I would emphasize it's very poor in the educational aspects of risk of HCC codes. For example, our problem list routinely prompts physicians to code for HCCs for cancers, and yet it doesn't indicate that the cancer has to be active or the patient has to be under active treatment to qualify for the HCC code. Our clinicians don't know that usually, and so we're overcoding in some situations and undercoding in other situations. So we need to involve education either externally from the EMR or somehow integrated into the EMR.
Thank you both for talking about the EHR and the issues and solutions that go along with that. Donna, I was wondering from your perspective, what do you think is the key ingredient to gaining an accurate picture of risk?
I think it's a more comprehensive data view of the patient. So that includes not only what's recorded at the encounter and the examination, but also what was billed on the patient or what was paid, and then what information went to CMS to adjust the risk. Sometimes there's gaps in that information flowing all the way through to the system. And again, the provider organizations need visibility to that information. And, you know, there's more and more we're hearing in the industry about other things that might not be in the EHR today, social determinants of health that are huge drivers of healthcare costs, et cetera. So I think relying on one single source of information is a shortfall for the industry. We need to look a little broader at the EHR and also patient-supplied data and survey data and also claim data and also CMS data to get a more accurate picture for risk and for population demographics.
I'll just add as a provider that the claims data has been incredibly impressive for me to look at. I didn't even know it existed. And until SCIO presented it to us, we had no idea how many potential outside claims for HCC codes had been made. And more importantly, it gives us information on who we might look at as far as patients to see what HCC codes they may be missing. So it all works into one plan that we have with SCIO, and I think we're much better suited for dealing with risk and HCC coding since we've aligned with them.
Yeah, a lot of the electronic health records focus on what's in their network or what's in that particular electronic health record system. So providers that are outside of that particular EHR or outside of that network, those visits may not be visible to the provider, and they can contribute significantly to risk and to the conditions and the services. They certainly have a lot to do with the services the patient, healthcare services the patient is seeking. So it does require a broader view, I think, of information to be able to close those gaps.
Excellent. So, Bill, I wanted to go back to one of the slides. The survey indicated that nearly 45% of respondents are unable to take action on closing open care or documentation gaps. Do you think did this surprise you, knowing many of them are using their EHR systems?
Having been through this over the last 2 years with the new EMR system, I have to say I'm not surprised. How you put the information into the system is totally the determinant of what you get out of the system. So, for example, we had a big corporate objective for diabetic eye exams, and we knew that we were doing really well with performing diabetic eye exams, but if they aren't put in the Epic system under health maintenance, there's no way of pulling it out. So you actually don't get everything in the EMR presented to you for these quality gaps such as that. So it takes a lot of time to be able to learn exactly how to put things into the EMR before you get valuable data out. One of the real problems we have is when we're scanning data from an outside entity, such as an ophthalmology report or a mammogram from an outside vendor. If you just scan it into Epic, it doesn't get added to your health maintenance unless you code it correctly. So we knew we were doing a good job on mammograms and diabetic eye exams, and yet we were falling multiple times below where we thought we should be until we really got our IT people to make it much more obvious to people in the offices where these things had to be added. So I'm not surprised. It's not something that you just open up an EMR and have everything presented to you. It's a lot of work. But if you do it, it will eventually give you that quality information.
Sure. And even though you may achieve a very high score on quality gaps in one area, for example, that doesn't mean that you don't have other documentation gaps in another. And like you said, when there's so many choices as to where the information goes, even if you do a great job of educating everyone to put it in one place, it doesn't always pull through, and it doesn't pull through on the documentation that really makes a difference in risk adjustment and in payments.
Right. We have 20,000 people who have access to NEMG's EMR, and trying to educate that many people to do anything correctly in the EMR is almost impossible.
You have job security, Bill.
Yeah, that's a good point, Bill. Absolutely. Bill, if you don't mind, are you able to talk about, you said the IT staff made it more obvious for the users. Are you able to talk about that a little bit?
Yeah, I can only talk about it specifically for Epic. But Epic has a health maintenance module where for each patient you could pull up the health maintenance status for about 20 different health issues for that patient, ranging from vaccinations to colonoscopies to hemoglobin A1C, for example, in diabetics. The most critical thing our IT people did was to make sure that any lab reports are appropriately input into the health maintenance so that we would capture the hemoglobin A1Cs, and that when we would scan something into the media section of Epic, that it would be pulled into the health maintenance module. If you don't do that, you have to go back in every patient and look in the media section of Epic to see if they had a colonoscopy, a mammogram, and no one was going to do that. So I can't speak to other EMRs, but there are, as these EMRs become more complex, it even becomes more complex to translate the information you're putting in there into the correct place so that you can pull it. So we actually have a structured data system with most of our providers, most of our payers, which automatically pulls information from Epic in data files that go to the insurers. And we had a lot of trouble getting the correct structured data input into the files that were coming out of Epic. We've taken about a year to get that under control, and now we're able to send routinely all BMIs, hemoglobin A1Cs, mammograms, diabetic eye exams, et cetera, all every month in a file that goes to our insurers. And that's really made our HEDIS measures go from what was initially a HEDIS level of 3 to a HEDIS level of 4.5. So if you put the work into it, that data is there in the EMR. You just have to know how to get it out.
Thanks so much, Bill. I think that was a good explanation for the audience, just in case, it's a practical answer that they can maybe learn from and input as well, possibly. So thank you for taking the time to do that. Donna, I want to go over to you. The survey results also showed that only 41% of respondents felt they had the ability to look at risk prospectively. Could you give us your thoughts on that?
Sure. Well, and especially if the EHR is the primary source of this information, it does a great job of showing what's kind of happening concurrently and what's happened in the past. But the payment system for many of these risk populations is prospective, meaning that the current care and the current documentation is going to predict how much revenue that organization or that provider is going to receive in the future. And so it's very important from healthcare organizations work on such thin margins that it's absolutely critical that they're able to budget, they're able to predict that revenue, and they're able to budget accordingly. And all of the services, especially in a managed population, that they want to supply, programs, care coordination, navigators, et cetera, all of that has to be taken into account in their budgeting as well. So the better they're able to understand what their current population looks like, address any gaps that they have, predict the revenue they're going to have in the future, and then create the programs that their patients could benefit from to better manage them. So it's a prospective system, and a lot of times just a current view of the state without understanding, what CMS's view, for example, of risk adjustment is, really disadvantages the organization from being able to budget and develop for programs that population needs.
I would just emphasize that if you don't know what's going on now, I don't see how you could adjust face risk adjustment prospectively. The most important thing is to get what's going on now and then to extrapolate from that.
Sure.
All right. Bill, to bring this topic full circle, what are some of the key best practices to ensuring behavior change across providers?
Based on all the data we've been receiving from SCIO, including risk assessment factors for each provider, missing HCCs per patient, and a global perspective of how we as a medical system compare nationally with coding HCCs, we've undertaken a major program on education. We have had 250 providers attend HCC coding boot camps, we call them. We've instituted for the largest providers number-wise and with sort of mediocre risk factors, we've engage in one-on-one education where I go and educate the providers on the 10 or 12 most important HCC codes for them to address. We can't have them learn all 79 codes. That's what happens at the boot camp, and they come out of the boot camp not really able to assess a patient's HCC status well. So we have them concentrating on things that are very important for us to capture, such as diabetic complications, morbid obesity, vascular conditions, depression, 10 to 12 things that we've identified, but more importantly, SCIO has confirmed that these are the HCC codes that we are not doing well. At the same time, there are some codes that we're overcoding, and that was a surprise to us. Since we're not doing that well with coding, we didn't think that we would really have overcoding. But as I mentioned before, cancer codes, the patient has to have active disease or under treatment. Otherwise, they don't have an HCC code for cancer. So those are all things that we're addressing with providers on one-on-one education. And SCIO is, at the present time, auditing charts of providers that we think are the biggest outliers in doing a good job on HCC coding. We are going to use the results of that audit to, again, go visit with the provider, talk to them about their specific problems with HCC coding, see how they do for a couple of months with the education we've given them, and then re-audit their charts and then revisit them. And I would expect we would see some significant improvements in risk factor for their panel of patients.
Yeah, I have to echo that. I think that, behavior change is the hardest thing to do, and it takes time to achieve. First, you have to know your benchmark, and education can be especially effective if it's very specific and targeted to exactly where that provider has missed some diagnoses and some documentation because of lack of knowledge, just not knowing the right way to do it that would be picked up on throughout the system and adjust risks. But it takes time. It takes not only the boot camps and the one-on-one education, the specific examples to them. It takes some re-auditing to make sure that indeed that change was made. And it takes a lot of reinforcement, and reinforcement can, take a lot of flavors, anywhere from just continual education to incentives that are designed as well to have a more accurate picture. But also it takes a lot of focus, it takes time, it's hard work, and it requires first and foremost visibility to the issue. It takes visibility, comprehensive data, understanding where the problems are, targeting them, not trying to boil the ocean, we always say, but trying to be very specific with where the outliers are that you can have the most impact on, and continual, very specific education, re-auditing, and reinforcement.
I don't think you could overemphasize the importance of documentation. Our high number of patient providers are not doing the greatest job at documentation. So even though we're identifying HCC codes in the chart that could have been documented and could have been billed, we're not seeing adequate documentation for that HCC code. So even though we're going in and reviewing the charts and could recapture some of these codes, because the documentation is so poor, we can't. What some of our regional medical groups have done, and we have not taken this approach yet, for the providers, they've actually made 20% of salary dependent on how good they do on HCC coding based on audits. We're not in a punitive method yet at NEMG. I think we're going to actually bonus people who do a good job rather than penalize people who aren't doing a good job, at least until we have the full educational program out there.
Excellent discussion. Bill and Donna, could one of you please talk us through the potential impact of inaccurate coding and documentation?
Well, there's a downstream effect. It's a real domino effect. As we talked about it being a prospective system, if you start off missing a lot of codes, in 1 year, that's going to carry over to the next year. And the next year, the slate is wiped clean and you have to start all over. But you're already kind of starting off at a loss. And so it's a bit of a slippery slope. And it really does take a lot of effort to get ahead of that cycle, to try and improve the documentation in a manageable way, the strategies that Bill's employing, very specific provider education, looking at the data, working with the incentive programs for providers, et cetera, really trying to audit charts and look for examples where they could be recaptured or where that could be turned into a very specific educational opportunity. It takes a lot of effort, but once you make that improvement, the other populations that are served by that provider audience will benefit too, and it'll also improve the underlying benchmarks for other risk populations within the organization. So it takes a lot of effort to start the program, but there's a significant downstream effect, either upside or downside, depending on how well you address that. There's a lot of opportunities.
So SCIO is addressing or is analyzing the claims of 10,000 patients of ours. But as I may have said before, we have 120,000 patients who are in one way or another impacted by HCC coding. So what we're learning from SCIO can be translated to these other populations. And just as importantly, the education we're giving providers will be for those providers to use across all different payers. But inaccurate or inappropriate documentation, if the code is billed for and there's not accurate documentation for it, then you're really at risk for an audit from CMS, which would not be pleasant. We are not heading towards that in many different areas, but there's a major insurer that's being sued by CMS because they're being accused of pushing providers to excessively code. Let's just say that.
Mm-hmm. So a good example on the compliance side of how that can put an organization at significant risk. And on the flip side of that, we started out talking earlier, and if you look at what our survey respondents said, most of them are in a position where they have multiple risk structures in place, and they are actively taking on more risk.
Right.
And we know that the market is moving to where that risk is moving more and more to having to take on downside risk or being forced into taking on downside risk, especially all our ACOs or MSSPs that are going to be forced to make a decision to move off track one, either take downside risk or exit the program. So the trends are showing us that you can't win by ignoring this problem. You could be in a compliance issue, in fact, and also the benefit to taking on more risk is, in order to take on more risk, as the industry is moving, you have to have accurate documentation. You have to improve the documentation to reflect accurately what that population really looks like and what conditions they have.
The one thing I'm really impressed by is the lack of knowledge of the providers that these need to be coded annually. HCC codes need to be coded annually every January. Once you get into that process and you start coding them, the following year is easy. But the first time you do it, it's going to take some time. And so we have it being performed at our annual wellness visit, and we're trying to narrow it down to 4 or 5 HCC codes that should be captured. But the providers keep giving us feedback that we don't think you need to capture an amputation every year. We don't think you need to capture depression or alcohol dependence or these things that are lifelong conditions.
It's in the EHR, right?
Exactly.
They see it in the EHR. It's right in front of their face.
Why should I document it? I document it with it. It's going to come back. Well, CMS thinks that it goes away and you have to redocument it.
Right.
It's a game to some extent, but it's an important game to understand.
To stay ahead of the game.
Exactly.
Mm-hmm.
Well, thank you so much, Bill and Donna. Great discussion there as well, and some of the things that providers really need to pay attention to. So what I'd like to do now is I have one more question that either one of you can answer, and then I'm going to transition us over to the audience Q&A, where the audience can ask questions of our two speakers. So Bill or Donna, if you both want to reply, we've talked a lot about coding and documentation tied to revenue, but can you talk about the impact on quality?
Sure. Is everyone seeing the slide that's up there showing accurate documentation, right? Mm-hmm. I want to just go over it very briefly because the first part of it is how NEMG is currently documenting. If a patient has diabetes, we get that. You can look at it. Okay. If a patient has diabetes, and all you say about the patient is that the patient is 68-year-old male, whatever, something like that, you get the 0.319 of the RF, which is just a demographic picture. If the patient is accurately coded, let's say with some education, you say that the patient has diabetes with complications, has vascular disease, and heart failure, all of which are HCC codes, and all of which have fairly significant RFs, which you add to the demographic RF, and you have an RAF of 2.186 in this situation. If you've had a contract, if the insurer has a contract with CMS to receive a certain amount of money per RF, in the first case, you would multiply that, and I think it's about $600 per month. You multiply that by 0.319, and that would give you $2,550 for that insurer to take care of the patient every month. The second scenario is where we've done a better coding. You multiply now a 2.186 times 600, and you get $6,000 per month. I think it's per month. And then if you go all the way and you really do a good coding and good documentation, you get diabetes with complications, vascular disease, with atherosclerosis of the lower extremities with ulcers. That's one of the higher RF factors, and chronic CHF. You add all those up, and it comes out to 2.485. And now the same patient with better documentation is now getting from the insurer, gets from CMS $19,000 to care for that same patient. Clearly, you're going to have a lot more profit taking care of the patient with $19,000 per month than $2,550. The quality part comes in is we now know this patient has a 2.45 risk factor. At NEMG, we are now stratifying patients by risk factor. And, for example, if they're in as an inpatient, we're going to make sure they don't get readmitted by having close care coordination. We're going to make sure they come in for their annual wellness visits and all their quality measures. That will not only result in more money, as I said, to the insurer to take care of the patient, but if you take care of the patient based on these quality measures and keep the patient from coming in the hospital, you're going to spend less money taking care of that patient than you would have. So the two benefits are the insurer gets more money to take care of the patient, it costs less to take care of that patient, and as a provider in a risk-sharing contract, we would make a fairly good profit out of that same situation.
And even to build on that example, vascular disease, lower leg ulcers, they're, referring the patient for diabetic foot care and for the appropriate referrals that they need, making sure they get their lab values, their A1Cs and their cholesterol, et cetera, every 6 months. Our quality gaps, their quality measures that are going to get reported.
Yep.
And the program will work better for the patient who is those services that they badly need are identified up front and coordinated through the organization. So the patient receives better care and hopefully can get into more of a preventive mode and less of a reactive mode or end up in the hospital or the emergency department.
In fact, there's a new study out by Optum. It was for a large California health system that's been doing this for 4 years. And their RF for their patient population was about 0.9. It went to 1.2. It went to 1.3. And then it went down to 1.2 to 1.0 because you were preventing the diabetics from getting complications, the diabetic with lower vascular problems from getting ulcers, the COPDs from becoming chronic respiratory patients. So even though a lot of people talk about this as far as the revenue potential, I think that if you use this information for quality purpose, you're going to get a double benefit for it.
Absolutely. Thank you so much, Donna and Bill. Your explanation of this particular slide just makes such a good case of why it's important for accurate and comprehensive HCC coding. So we appreciate that explanation. It's now time to move on to our audience Q&A, and I just have a few instructions before we do that. I do want to thank our speakers. Thank you so much for your expertise and just talking and discussing with us today about this important topic. So now is the Q&A portion of the program, and so I'd like to invite the audience to now ask live questions of our speakers. In order to do that, to submit the question, you would click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewable by other audience members. So while the audience is typing in their questions, I'm going to ask the first question, and it might be a question that sometimes speakers are often asked about this topic. So Bill and Donna, feel free to both answer or one or the other. The first question is, are you seeing risk adjustment as a focus within the inpatient setting as well?
We definitely are at NEMG. It's important because a lot of the acute codes that we not really talk about, the HCC acute codes, are seen in the inpatient setting. It's so important, actually, at NEMG is because providers weren't doing a good job on the inpatient setting, we have HCC billers going through the chart to capture all the HCC codes. And if the provider has not provided adequate documentation for the visit, going back to the provider and telling them to document HCC codes. In fact, our RF across our population, not including inpatients, is 1.0. And for our hospitalists, our RF factor, because they're seeing sicker patients, but also because they're having help with coding, is 2.0, double.
That's a great example. That shows the power of really making sure that you have accurate documentation on the inpatient side.
So the other providers are all arguing that we should have billing codes for everybody, all 200,000 patients.
All right, thank you so much. Okay, all right, our next question for our speakers is, do you see clinical chart reviews as a necessary component for risk adjustment?
I really do feel that it adds a lot of value because, first of all, there's a delay. There's like 15 months to be able to submit supplemental information through the payer back to CMS for risk adjustment. So by doing chart reviews, you can find documentation that is adequate to support these diagnoses. And because it's a prospective system, it's in the best interest of everyone for that patient to get accordingly the appropriate documentation updated and through the system. And it'll influence what gets documented in the following year. So it is important to spend that time. Another, one of probably the best use case I can illustrate working with Bill here at NEMG is that it helps us identify patterns, especially with specific providers or across specific conditions, where we see the same documentation mistakes made. And it's not, the providers don't know. The rules changed or it just isn't evident what they need to document about a condition to get appropriate credit. And we certainly want to keep them out of any compliance situation that Bill referenced earlier. So it is just a great source of useful, specific feedback on how providers can improve their documentation so that the credit, the appropriate credit and risk adjustment occurs. And it's probably the best source of that. And I'll tell you another kind of unintentional consequence. We've also learned a lot about looking at the charts and where there might be documentation gaps or claims missing, et cetera, that gave us an opportunity to go and chase that information down further. So it's kind of opening Pandora's box It gives us the opportunity to really follow through the entire cycle of that documentation, how it goes through the system, how it gets to CMS, which we consider kind of the source of truth, especially if they're the payer, if you will. They're providing that information, that payment back to the plan and back ultimately to the provider organization. It helps us trace those issues and resolve them, because at the end, visibility to the, having good data, complete, accurate data, and visibility to that at the point where it really matters, when the provider is examining the patient and documenting their conditions, is really what the loop that we're trying to close here.
I'm trying to visit our top 50 providers, and there are two parts of the education process when I visit them. One is to talk about the top 10 to 12 HCC codes that across NEMG are important for us to capture. But just as importantly, and I think it hits the provider more at home, is we tell them in audits of their chart reviews what they specifically missed, overcoded, undercoded, and poorly documented. There's a tendency of the provider to say, I know how to do HCC codes, I know how to document, I'm not doing any of those things wrong. We're going to be pulling out 10 of their charts and showing them, well, you didn't really do it in this patient, and it would be really important that you do it in forthcoming encounters with patients. So it really helps us. All the coding information you're gathering from the chart review is very important for us to specifically tell an individual provider how he could help himself or herself.
Great. We have time for one more question. So Bill or Donna, whoever would like to answer this, when you say take more risk, do you mean take additional patients with high risk, or is it moving to models where there is more risk?
I think it really means,
Right.
yeah.
No, it clearly is not trying to get more sicker patients into the population. I always tease my colleagues that one of the easiest ways for us to reduce our problem patients is to send them someplace else, but that doesn't really make good sense. We want to quantify the risk of our patient population that we have now. The risk that we want to accept in the future is a risk of losing money if we don't take good care of those patients with adequate amounts of money allocated by the insurers to take care of those patients. So the added risk we're talking about in the future is really a monetary risk. The risk our patients have, we're just trying to quantify that in a population we already have. But the risk is that you could lose money if you don't take care of patients in a medically revenue neutral way. So if you're spending too much on patients, that's the risk you're accepting, that you will lose money.
Right, and the other aspect, I think, of risk in a population, it really comes down to understanding the population that they're serving and what their needs are. So accurate documentation, accurate risk adjustment also not only relates to the finances, as Bill described, but it also gives a picture of the programs and services that are needed. And to keep the patient avoiding, to keep them, to move them more in a prospective treatment, proactive treatment, quality care, efficient care mode of practice, as opposed to a reactive mode of practice, ending up in the emergency room or in the hospital, or never being seen by anybody, or going to lots of different providers and not having coordinated care. So trying to prevent patient risk means documentation that also accurately reflects the population risk that you can better manage, because the revenue is driven by that.
Right. So our goal is to reduce the risk of each patient.
Correct.
By improving the quality. Right.
Yeah.
Terrific. Well, thank you so much. Unfortunately, we have run out of time for questions, but I just wanted to say in closing that to our audience, we want you to know that your feedback is very important to us. As you'll see on screen at the bottom of the current slide is a link to the evaluation. A live clickable link can be found in the resource list as well as in the program evaluation widget at the bottom of your screen. And it will also appear in the slide window at the conclusion of the program. We would greatly appreciate your thoughts on our program today. Finally, I would like to thank our speakers, Bill and Donna. Thank you so much for joining us and sharing your knowledge on this topic. And to our listeners, thank you for all joining us today and watching our program. We hope you found it informative, and we look forward to providing you with other helpful programs in the future. Ladies and gentlemen, this concludes our program. Thank you again for joining us, and have a wonderful day.